but while we're continuing to wait a little bit for them to get here, maybe we can go around and introduce ourselves. I think we have a couple new folks here, people sitting in for others, et cetera. So Peggy, do you want to start us around the table?
Eric Wagner, Executive Vice President from MedStar Health.
Dave DeMarco, Maryland Citizens Health Initiative.
And Sam Conan, CEO of Maryland.
Steve Farley, former Commissioner and Vice President at Optum.
Pat Bass, Chair of Clinical Integration, Anne Arundel Medical Center.
And Howard Hess, Deputy Secretary of Public Health Service.
Donna Kenser, HSCRC.
Jack Meyer, Health Management Associate.
Carmela Coyle, Maryland Hospital Association.
Deb Gracie, Health Management Associate.
Izzy Firth with Lifespan. Ann Scavera, Consumer Health First. I'm sitting in for Lenny Preston.
And Cynthia Flagg, United Healthcare, sitting in for Gary. And I'd like to congratulate Peggy on the most admired CEO in Maryland.
Wow.
I was going to say, you're not there looking at Gary.
I'll tell him.
I'm looking at Cross and put us back there.
And on the telephone, who do we have on the telephone?
This is Joe Ross, Curtis Medical Center.
Gene Ransom, MedChi.
We also have David Blumenthal on the phone, but we're just working through some tech issues.
And we also have David Blumenthal on the phone, and we're working through his microphone issues. We've also invited Mr. Peterson to sit with us while we're deliberating on the strategic plan. So Ron Peterson from Johns Hopkins has just joined us, for those of you on the phone. And well, thank you. We have an agenda of making our way further through the strategy blueprint that we shared in the last meeting. We have an objective of working our way through the details of the strategy and plan that we'll submit to CMMI on around January 1. In terms of the order for today's meeting, we're going to change the order up a little bit because Dr. Haft needs to leave and head out to some part of the state to solve some problems. I know he was busy over the weekend with flooding and other public health issues, and he's going to be to leave us soon. So we're going to ask him to talk a little bit more about the primary care initiatives in the state before he leaves. We just had a couple of other folks join us at the table. Bob Krensick from the University of Maryland, Kevin Sexton from the Holy Cross Health System, and Steve Force. I saw Steve just also walk in the room. With that, we'll ask Dr. Haft to talk a little bit about the primary care opportunities, and we'll get back into them again as we go through the blueprint. Then we will kind of give an update on the draft that we shared last time and some of the changes that have been made to the draft, and Deb Gracie and Jack Myers will take us through that process. Then we'll share some of the very high-level discussion about potential strategies and the general principles behind those possible strategies. And we will finish up getting some comments from SEIU as well as comments from other folks in the public. So with that, I'll turn it over to Dr. Haft.
Thank you very much, Donna, and thank you for the indulgence. I do apologize for having to leave early. It's been a little busy, but that's not the only reason. I have a commitment on the Eastern Shore, but you can be sure that I will, as soon as I leave here, call in so I don't miss a word of this very important meeting. And I really wanted to just spend a few minutes again talking about and reaffirming our interest and my interest in primary care. We feel strongly that having a strong primary care foundation is critical to the sustainability of a good healthcare system going forward in Maryland, in the department, in the Office of Population Health Improvement and the Office of Primary Care are joined together in an effort to make sure that that happens. And as such, we've been involved for many years, as you know, with stakeholders, looking at issues surrounding primary care and continuity of care and those issues, and have come up with, over those many years that we've been at this, I think a strong set of principles that have been endorsed widely. And now we've been faced, as you know, with the repeal of the SGR, with a new model for supporting through Medicare funding some additional ways to solidify that intent to have continuity of care, comprehensive care, and care coordination. And I think with that, opened the door in concert with what has been an ongoing process with the Medicare waiver for hospitals to really align the initiatives of the provider community together with the strong initiatives of the hospital community to create healthier communities and have coordinated, comprehensive care. We saw recently that CMMI Medicare had released an opportunity to make Maryland one of the CPC plus states. I understand in a somewhat official, or I should say an unofficial way, that we were not fortunate enough to be one of those designees as a state. However, in discussions with CMMI, I believe that there's still opportunities to have a CPC-like plus program in cooperation with commercial payers and Medicare and Medicaid in the state, which would be extraordinary and probably time-limited opportunity. As you know, CPC does a lot of CPC Plus does a lot of the things that TCM, the Chronic Care Management Codes, had been hoped to do with care coordination. But CCM never really achieved the traction, I believe, that Medicare had hoped. It was somewhat cumbersome and presented some significant obstacles for the providers. So I think in general we can say it was not a slam dunk success. And CPC Plus, in many ways, is a much, at least the model that's presented there, is a much simpler model to execute. And in the vision that we have and that we've discussed with CMMI, would be more of an eclectic model, one that would not be solely tied to a primary care provider who was only family practice or internal medicine or nurse practitioner, but could be more specifically and appropriately the patient-designated provider. That is, if an individual, for instance, had primarily psychiatric disorder, as many of our dual diagnosed patients have, it could be a psychiatrist as a primary care, or if they were primarily a heart failure patient, they could be a cardiologist, a gastroenterologist for inflammatory disease, et cetera, et cetera. So more of a broad-based model incorporating more of the provider community in concept. And I believe this is the direction that that we all want to go in, to have models that align and are able to coordinate care across the continuum with as many of the providers and in as many ways it aligns with the hospitals as possible. And this, I think, in many ways, the CPC Plus, if we are able to find those arrangements now with CMMI, would satisfy much of the needs of the community. Not the only model, perhaps, but as a strong base for what other models might be in terms of coordinated care. It's our understanding that a CPC Plus-like model also would fit well within the constructs of an ACO. Well aware that ACOs have been broadly, and widely, and very recently established across the state. And these two models are certainly compatible. So over the last weeks and months, really, we've vetted these ideas through the leadership of the physician community in the state, through MedChi and through primary care leadership, through hospital leadership, through physician hospital leadership, through small practices, large practices, urban practices, rural practices, and have had, very interestingly, uniform and very resounding support for a model just like this. I think the physician community recognizes, or the provider community recognizes, that we are at a crossroads, and that part of that crossroads is that federal government is, in replacing SGR, has given us some options to join, or given the provider community options to join an advanced APM, of which this would theoretically represent, or to be in a MIPS-like program. And of the two, the opinion of the provider community clearly is that if an advanced APM was available, that would be preferable to them in many, many ways. So the providers have encouraged us, I think, to do what we need to do to put our shoulders to this, knowing that it's a very aggressive timeline to put together the details that would be necessary to be included in end of the year submission in concert with the waiver requirements, but still possible. And with the willingness of the hospital community, HSCRC, the providers, and the department, I believe that is an achievable goal, and one that is certainly worthy to go for. I look at this really as this is one of those times where we have an opportunity that is almost too good to let go by. The political winds will likely shift one way or another next year. People will change. Opportunities that are here now will likely go away. And although we all agree that there's nothing that anyone wants to do that would harm the very strong hospital structure that we have, or impede the ability to meet the goals of holding or lowering the total cost of care, I think it's our belief that this is in concert with that and not in conflict with it. So I am free for questions.
Thank you, Dr. Haas. Speaking as a family doc, chair of a Medicare ACO, president of the Maryland Academy of Family Physicians, I want to throw in my wholehearted support to this idea. This is so exciting. This is a dream come true. We know that you can't just shore up hospitals. You can't just shore up primary care. I love the idea about broadening what is a primary care provider for a medically complex person, a high utilizer. It is not always a primary care physician in the traditional sense. I feel that the CPC Plus, we have to think of some other name for it, maybe CPC 2 Plus concept is incredibly exciting, because we've been thinking for a while, how could we make the all-payer model leverage to be the advanced alternative payment model for our state's physicians. So I just want to say I agree with you. I think the timeline is short. We need to get this done by the end of this calendar year if we hope to have receptive ears that are still there at CMMI, and we will do whatever we can to support you in terms of physicians being at the table for the design, the implementation, and the governance of this program.
Comment, Howard?
Yep.
And I'm trying to figure out now how these two things feather together. I know Jean Ransom is on the line. You and Donna, in receipt of a letter, as asked, we convened the hospital representatives and physician representatives from this advisory council around the table. We too think this is really an important opportunity to explore. Obviously, we've got to figure out how to connect not just the physician pieces, but the long-term care pieces, post-acute pieces, and others. And in that letter, I think, expressed the importance of the exploration, outlined what a work plan might look like, and we can get this to other members of the advisory council. I think our only question was an ability to deliver by the end of December. And if there's a caveat in that, it is not that this isn't important or doesn't need to be done. It's just that the exploration needs to move ahead prior to at least those parties involved in those discussions being able to commit to say yes or no. But just some more detail on the bones. But I think we too look forward to that exploration, a very rapid exploration. I think there's a sense that December is a pretty big list, given that we're talking about many of the same people involved in the development of the strategic plan due at the end of the year. But we too look forward to the exploration of what these models might look like.
Thank you.
Any other comments for Dr. Haff before he has to?
Can I I don't know how to raise my hand when I'm on the phone. I don't know what the rules are for that. Can I talk real quick?
Sure.
This is Gene with MedChi. I want to say that first of all, we were supportive and went on all the calls with Ben Steffen on the CPC Plus originally. We liked the idea of doing that. So obviously, doing a specific model that was payer neutral and was APM compliant and was actually maybe even better for Maryland doctors and hospitals is something we'd like as well. And I've had the opportunity to talk to a lot of my key members over the weekend about a concept like this, and they're very excited about it as well. I also think that it's really good timing because Carmela mentioned that we've had these meetings with the hospital representatives and the physician representatives. We've kind of outlined areas of agreement, and I think the first good thing was everybody said we want to work on something together collaboratively, and then we pointed out things that we need to work through. And I think that what Dr. Haft is talking about is perfect because it can achieve all of those goals. So it sounds like we're all kind of heading in the right direction, in the same direction, and that's a big positive to me. So I appreciate this idea, and I'm looking forward to Dr. Haft kind of laying out a work plan and a timeline and telling us what we need to do to roll our sleeves up and start doing the work to figure out what we need to get done and when we need to get it done so we can make this thing a reality. So I'm excited and I'm optimistic, and I think that when we can get that kind of white paper draft starting point of agreement out, you'll see that what we were talking about in our little group is very similar to what Dr. Haft is talking about, and we just have to work out those pesky details. So I'm very, very optimistic today as to where we are.
Thanks, Gene. And Howard, we probably ought to let you go, but it sounded like you're going to call in by Bluetooth. So if in doing so you want to make a comment or a reaction, just give us a shout.
Thank you very much.
And, seriously, and have a good trip. Thank you for coming.
And just in terms of CMMI support for the process, also CMMI has expressed a willingness to meet with the state as well as selected stakeholders on a bi-weekly basis to help the process move along toward a goal of meeting an end-of-year submission. So I did just want to also mention that those conversations that Dr. Haft had had with CMMI about getting further direct input into the process as we move along with the planning process. So thank you, Dr. Haft and Bob.
General question, Donna. Our current Medicare total cost of care metric is tight.
Yes.
To everybody. And it looks as though these primary care initiatives will have some incremental cost. What do you think the willingness is of CMMI to adjust for the cost of this initiative?
Well, the initial discussions that Dr. Haft has led with CMMI is that they would be willing to look at this. They don't want to hold the model. It's probably a matter of timing because the rest of the country does have CCM, and there is certainly a major push from CMS to get a program out there that really changes the way primary care is delivered. So they tried with the CCM, and the CCM is a good concept, but and a good program, but it has a lot of billing requirements and a lot of hurdles that have made it difficult. So CMS already put the money out there, but it hasn't gotten out the door yet. So the conversation has been, yes, they're absolutely interested in making sure that the timing of us possibly getting money out the door faster than other parts of the country doesn't deter us from doing this and making an adjustment in the model in the short term to take into account the implementation so that it's held apart from the existing model in terms of the cost of implementing the program. So, so I think that's really the conversation that has been had, and obviously we would need to go back and determine how the calculations would be made, et cetera, and so forth, and understand the cash flow of the model. So if we were successful in the design and implementation, we would complete the design, the preliminary design in December. There might be some changes to it as it works its way through a process at CMS over the course of a year, and then it would be implemented January of 18. So if we were successful and on track with the process. And then we would need to take into account the money that would be going into effect in January of 18 and keeping that out of the process for a specified period of time so that we're letting others catch up. But hopefully with our all-payer model and the structures that we have in place, that we would be able to move quickly because it's very much aligned with what the hospital model is also trying to do. So it seems, as Pat said, a really good opportunity for an intersection between what needs to happen in primary care to make it work with an aging population with chronic conditions and what the hospital model is trying to accomplish. So definitely need to make sure that we don't throw hurdles in front of that process.
Donna, can I ask just two clarifying questions? And I just want to be clear. I hear you talking about it, having this done in December. I think the group that met of hospital and physician representatives from the advisory council were very concerned about meeting a December deadline. Timing may be set aside. We should just get about the work and see where we end up without necessarily rushing for that December deadline. Could you talk a little bit about the process? Because at our last advisory council meeting, Dr. Chaw was here and sort of put the challenge in front of us. As you know, we pulled together a group and came back with an answer. It sounds like there may have been more meetings taking place with Dr. Haft and others. How do you see the process unfolding between now and the end of December, and how do we make certain that the key stakeholders are really closely tied to CMS?
Well, I think we had a follow-up conversation with CMMI to discuss some of the preliminary questions that we had and to get more details about their thoughts, and also to just begin further organization process, because it is a significant process to get from here to January 1, and we talked about having biweekly meetings, and I do think that there's
with stakeholders, or is that going to be the state and CMS?
We felt that we would need to have a number of meetings with stakeholders because the timeline is pretty short, so it doesn't really lend itself to not having stakeholders involved in some of the conversations with CMS. So I think we're focused on having a set of stakeholders in the process of a number of the meetings with CMMI between now and the end of the year, and really to put our shoulders into it. And the Office of Population Health had already done some data analysis relative to primary care. Of adding to that data analysis, we have public Medicare files that tell every doctor in the state and every number of Medicare patients and their E&M billings and all sorts of data that we can quickly pull together to help get behind the process. So, and really get together with CMMI and see if we can come out with a joint work plan to bear down on it to get where we can get by the end of the year, with the idea that it is a really significant opportunity for primary care. It's a significant opportunity to bring some funding for care coordination in through primary care, as well as in through payers and hospitals. And also, it's a significant opportunity to have the process where the primary care doctors could get a 5% bonus under the APM, at least starting in 2020, if the timelines stay the way they are now. So just trying to lean into it and see what we can accomplish by December 31.
Good. Okay, I think we're ready to transition to my colleague Deb Gracie in a moment. Would it be okay if I just said a word about the report that was just completed?
Yes.
I'll do that and be very brief because the real presenter today is Deb. But I just wanted to thank the members of the Advisory Council for giving me, I can't remember if it was 4 rounds of comments on the report of the council or 5. I'm thinking it was 5. And you were all represented in the report. There were a couple times I was on the phone with one member of the council who said, do we really need paragraph 4 on page 16? I'm not sure it adds all that much. I said, yes, that's a verbatim paragraph that one of you wanted in there, word for word, and that person only asked for 1 or 2 paragraphs, so it has to stay. So I'm hoping that when you read it, you'll see some of your own words. I did try to withdraw from everybody's contributions while at the same time streamlining it so that it wasn't a scattered collection of comments. I'm not sure I pulled that off as smoothly as I wanted, but I made every attempt to reflect all the good advice and still have it read like a report. I just wanted to call out for special thanks. All of you contributed, but my good colleague Kevin Sexton, who just really took this so seriously and right up to the very end was on the phone with me, willing to take time, spending an hour on the phone or 45 minutes another day, walking through the report, helping to smooth it out and just add some good common sense and good catches. All of you did that, but Kevin really went the extra mile, so thank you, Kevin. So it is up now on the HSCRC website. It will be distributed. And the only other thing I wanted to say, and of course it's available to DHMH for them to make available as they see fit. The only other thing I wanted to say is this is, as you know, not the final word on this subject. We felt that it had been through many rounds, that it was good to get something out there that's a report of the group, but as the last few comments have illustrated, there's much more work to be done, and through the remaining months of this year, the council will still be speaking in one form or another, still be advising, so I didn't want any of you to think that a curtain was dropping, because it's not. It's at your thoughts as of end of July. And thank you. Deb, why don't you lead us through the next part of the discussion?
Sure. As with all of the work we do, thank you. This was a joint effort, so
here, let me give you this.
We would, okay, thank you. Ask everybody to join in as we have this discussion. So when we last met, we walked through as a group the strategic blueprint, which is the beginning of the progression strategy that is intended to be submitted to CMMI by the end of this year as to meet the requirement for the next step in the all-payer model. The way it's working is that we took all of the comments that we got from you at our meeting and all of the comments that were submitted to us since that meeting, and we integrated them into the blueprint, which they're in there, and you had a chance to look at them again before this meeting. And then eventually this will be taken out of the blueprint format and into the strategic plan format. So just want to make sure that everybody's clear on the process that we're using in order to create the progression strategy that will be submitted to CMMI. So the comments that we received so far have been around the subjects that we talked about last time. Today, we'll be talking about the models. You'll see, at the end of the blueprint, there is still no information about the models, right? It's to be filled in. So today, we will spend a lot of time talking about the models, the strategy around the models that would be included in the progression strategy document. And from that, we will move that conversation into the blueprint, send it out for comment. You'll give us what you think, we'll revise it, and then eventually, move it into the strategy. So does everybody understand the process that we're using with this group of stakeholders and other stakeholders as well to develop the strategy? Any need to talk about that, or are we good on that?
So So is it still your thought that this will be a consensus view of this group?
A consensus view of the group. Well, we're taking advice from the group, and we are certainly building in the comments of the group into the strategy. As far as consensus, I'm not sure if it's quite that far.
Hopefully. Hopefully it would be consensus, but even in the report, I should say this, that was just published, there are divergent views noted, and so we don't expect unanimity. As Deb said, we're trying to get the best views, so I'm not sure, it'd be great if we got a consensus, but we're not trying to force one. We really just want to get the best ideas in there.
Yeah, I think there's another planning process going on as it's underway relative to dual eligibles, and so that process is gaining its own input and consensus, and so that's been put together in
I'm going to talk about
document.
that next. I actually was going to spend some time on that.
Okay.
So I just want to make sure everyone was clear on the documentation. Kevin?
On this issue of transitioning from the outline, what's the role of this paper that we have just put out, this implementation and future direction of Maryland's all-payer model relative to the evolution of this document in your mind?
Well, we've already taken information out of that, and so for example, if you actually start reading the principles that are in here, many of those principles came out of that other document in, several months ago, but they're actually pulled into this document from the other document already. And so we were attempting to take that document into account, that input into account as we develop the strategic plan and the outline for the strategic plan. So, for example, the principle of making sure that as we experiment with, as an example, as we experiment with new models, that we don't affect the hospital model in a negative way, and that we have the ability to cut off new things that aren't working without having to redo the entire hospital model. So that principle is clearly, for example, reflected here in the design principles and effectively in the negotiation principles to take forward with CMS. So that's just one example where if you look at the recommendations that you put forward, that you would hopefully start to see how they have already showed up in this document. Is that helpful?
Okay, so one of the major changes that you may have noticed in the blueprint was from a letter that we received from our friends at DHMH and the dual eligible work group. I think many of you are aware and maybe even participating on the dual eligible work group. They're developing a dual eligible model as part of a SIM grant that they received. And it became an important part of their comments to us was the fact that there's a huge focus in this progression strategy on total cost of care in many different ways. Moving towards a focus on more and more total cost of care as we move through the progression in a number of different ways. One of the things that they wanted to make sure got reflected in here is that for the dual eligible population, the total cost of care, whatever we build, whether it's a guardrail or whatever, needs to have consideration around the idea of Medicare and Medicaid total cost of care for the dual eligible population that is in the dual eligible model as it gets implemented. So we thought it was important that we called that out specifically, since it's such an important concept as a whole in the strategy that you are working on, and that's why we pointed it out so many times. As we're building the models, which, it's going to take time, as we're talking about, this will be a phased approach to building the models. But as the models are built, we will need to give consideration, as we're thinking about the infrastructure, for instance, that's needed to support the model. It won't be, we'll have to say to ourselves, this can't just be about Medicare total cost of care. We'll have to consider the Medicaid portion of the total cost of care for the dual eligible. So it's going to need to be, a conscious thought process to make sure that we're considering that piece as Maryland evolves over time. Anything more you want to say about the dual eligible piece, Donna?
No, I think we'll be looking more at what the figures are on that in just a few minutes, and one of the things that we sent out and that you can bring to the side of as you're looking through the documents is a little facts and figures sheet that breaks down some of the costs, but we'll also be going over them in the PowerPoint just so that we can, what does that mean from a cost standpoint and how does it relate to the overall model. And I think there are multiple reasons to integrate it, which we'll get into in some more detail, but a number of the strategies are overlapping, and so it was important. It's been important to CMS, but also important to the state to make sure that there's a definition of how it's going to work. And there's also concern that as folks do things on the Medicare side, that it could inadvertently shift costs onto the Medicaid side, and so needing to really keep a close eye on that as the Medicare strategies are implemented, that it doesn't result in unintentional cost shifting into the Medicaid side. But also just realizing that a number of the care coordination strategies are really interlinked between the Medicare and the Medicaid side for the dual eligible. So we'll get back into that, but that's really the thinking of BHMH in terms of making sure that it's tightly integrated into the process and of Medicare, and making sure that, or CMS, and making sure that it's tightly integrated into the process. And probably at a very soon upcoming meeting, we'll have a presentation of a little bit more of the detail of what that work group has been working on for the last 6 months or so.
Can I ask Deb, has that work group actually dug into what it, not only what it means, but how you would create a Medicaid total cost of care guardrail? I'll be honest, in looking at this, this is the piece that raises the most question and concern in my mind. If we look at what we're currently playing with, a Medicare total cost of care guardrail, it makes a lot of common sense, a lot of policy sense, but the operationalization of that has been challenging at best. When we think about adding a Medicaid total cost of care guardrail, now we're really out there. And just wanted to ask, I haven't heard a lot coming out of that work group that's really dug down into what it means to apply this. I, in my own mind, again, conceptually it makes sense. The idea here is we shouldn't be doing anything in this model that's shifting costs from one place to another, but how you actually do, and if you think about the lessons that we've learned from having a Medicare total cost of care guardrail, especially one with no exceptions, that in itself has been challenging, and when we get to Medicaid, it just starts blowing my mind. So any discussion yet on that?
So from my perspective, it's all being looked at the model, at the deeper models, not at the all-payer model level at all. It's down into the dual eligible model itself. And there have been some discussions about it, but they're very preliminary. I want to give Donna the chance to share any discussion she's been in, and I think Trisha's also back there.
Yeah, I think, and I'll, if others from DHMH want to add anything, but the discussion right now in the dual eligibles group is about having a total cost of care focus at an ACO level in the more populated areas of the state, which is yet to be defined. So some folks think that the less populated areas of the state would also be amenable to having an ACO type of model focused on total cost of care. And in areas where there weren't enough beneficiaries to use a managed care management model, a managed model to focus on the total cost of care for those dual eligible. So that has been the conversation that has been continuing in that work group, and so that's how the focus and measurement would come about, is through the implementation of those models, the ACO model or the managed model. And I think we will be scheduling a presentation from specifically on the details of that. Trish, did you have anything else you wanted?
Do you want to add something to that?
I mean, the only thing that we, with our letter that we were tying, because CMMI has been asking us to incorporate our model with what's happening with the all-payer model. And so we're linking the two discussions together and saying, well, we're laying out the progression strategy on the all-payer model. We need to make sure that we're conscious and linking the discussions that are happening with the duals. So that any discussion that goes beyond, that talks about total cost of care, needs to include the Medicaid services that are provided to those individuals. So, if there were specific carve-outs that you wanted to talk about, we should talk about it. But in our discussions, we say no, there are no carve-outs. And what we're looking at is the total cost of care for all services that are being provided to the duals.
A question on the current waiver metrics. I assume the duals in the first metric, the all-payer per capita metric, I assume the duals are in there. Whereas when we get to the Medicare metrics, the 330 million savings metric and the total cost of care metric, I would assume the duals are not in there?
The duals are in there. So all of the Medicare beneficiaries who are fee-for-service are in the savings calculation, the savings test. So the duals are in the test. The Medicaid spending is not in the test. The Medicare spending is in the test. So the Medicaid spending is not in the savings test. So, that will be a point of discussion. So the Medicaid spending will still not be in the Medicare savings test. The question that we need to answer is how does it get incorporated in the model here. And the work group discussions to date have been around an ACO model and a managed care coordinated model for those that of the state where there weren't adequate beneficiaries to have an ACO model. Eric?
Don, another question in terms of as you all are conceptualizing the so-called ACO model, is it an upside and downside risk? And if so,
yes, the work group has talked about upside and downside risk. They are at this point talking about downside risk starting in year 3 of the model, but that hasn't been finalized. So if the model started in 2019, then they were talking about I would say mandatory upside risk, if you would want to put it that way, for the first 2 years, and in the 3rd year there would be downside risk as well as upside risk in the 3rd year. So that's at least how it's been conceptualized to date. It's not finalized, but that's a conceptualization.
And so when you talk about that and you talk about total cost of care guardrails, if you will, the question that comes to mind is who bears the downside risk, or who bears the penalty if you come up against the guardrail, and what's the remedy? Because right now the only people that are on the hook are the hospitals.
Well, that's definitely not the conversation in the ACO room. Is definitely talking about a much expanded audience of participants, particularly. We'll be looking in the slides in a minute, but we have a $1 billion worth of long-term care provider cost in the model. So the requirement and the presumption is that we'll have long-term care participants in the ACOs. And as I listened to the conversation, it appeared to me to be mandatory to have the long-term care participants in the ACOs. So I expect that we'll have other participants, significant other participants, in order to have an accountable care organization that has more than 50% Medicaid costs, because when we look at it in a few minutes, we'll see that we have to have those providers who are the most significant portion of the cost be foundation cornerstones of any ACOs that would be going forward.
Yeah. So it is at the ACO level. It's the ACO. And it's the ACO that's taking the risk. The dual eligible ACO, as John explained, right? There will be.
So we have an ACO, we MedStar.
Mm-hmm.
We take the risk of its performance.
Mm-hmm.
We had to put up money,
Mm-hmm.
letter of credit to guarantee that performance. So who is going to do that?
ACOs that are bidding on the work that they put out, and there's still a lot of work that the dual eligible ACO work group is doing. So the current ACOs may have the opportunity to become a dual eligible ACO, but there will be different rules associated with it, which are being worked out in that work group. But the ACOs that become the dual eligible ACOs is who will take the risk. I really do think that what we should do, because I mean, Tricia, and talking to Bob and others, they did offer to come, as guest speakers to this, and explain the dual eligible where it is now, even though it's not finalized, which describes all of this. Would that be appropriate from your perspective?
Yeah, we would be happy to come and give a presentation. I know many of you guys have representatives from your organization, so hopefully they're communicating back to you as well. But yeah, we'd be happy to come to this.
Yeah, because when the dual eligibles, when the ACOs start to bid on that dual eligible work, that's where it'll be clearer as to what the rules are going to be for you, for those.
And I would say, thank you, Tricia. I never put anybody on the spot, and thank you and Bob for agreeing to come back and talk to us more formally. But if, as these questions come up today, like Eric's question, and you have a thought on it or a good answer to it, chime in.
I was just going to actually invite Trish to come down and sit at the table with us in case there's questions as we work through the initial presentations today, to just come on up and help answer questions.
And may I ask, Donna, I mean, what might be helpful is, because there has been a separate group doing a lot of work on this dual eligible model, can you share with us how you see these two pieces coming together? And it's this, the conversation we're having as we think about connecting all of the pieces. There's a core model. We're now talking about a physician model, a post-acute model, a duals model. Maybe it would be helpful to understand how you all see that connecting, and when we talk about, excuse me, a Medicare total cost of care guardrail under the core, I'll call it the hospital model for a moment, what does it mean when we then start talking about a Medicare, Medicaid total cost of care guardrail? Are these separate pieces? Are they integrated? Will we all be connecting to the same total cost of care spending? It's where that comes together that I think raises some.
So at the hospital model, there's not talk of changing the total cost of care guardrail in the ACOs for the dual eligibles, right? That's where you would encounter a total cost of care metric. Let me change the word guardrail. I think that's where I took us off, was using the word guardrail, because I think people are thinking about it at the hospital model level, and I'm talking about it at a deeper within the ACO model, right? So there is work that is being done to ask ourselves how that is connecting, because I mean, I think it's a valid point, Carmela, and we have to think through that, and we're starting to think through it now and understand how it all functions together. But the dual eligible model in its current form for the Medicare and the Medicaid spend is really within the dual eligible. It's not at the hospital, GBR, all-payer model level.
I mean, there's been a focus on trying to think through it for more than 6 months, so to make sure that we're trying to connect things in a logical and appropriate way. So, but and a lot of things really are very connected. So the dual eligible beneficiaries are pretty expensive beneficiaries, and so they need care coordination. And so it's very connected in that sense. It's connected in the sense that we're thinking about a health home for the dual eligibles, and I think over half of them are under 65, and so they have serious mental health issues. And so the mental health component of the plan here, but also the idea of having a health home where a mental health professional might be the patient designated provider in a model, and then of course we have post-acute and long-term care considerations here, and of course, they're front and center in the dual eligible model. So I think the pieces are very overlapped, and we're really focusing on how to make sure that they come together in a meaningful way. So we need to talk about it here, but also there's a lot of conversation about it in the duals work group and outside of the room among the state staff and the consultants of trying to make sure that we're working toward a process to make sure that things fit together.
Original question was around FQC, the federally qualified health centers that manage the homogeneous Medicaid population. Are they part of the dual eligible discussion? They are actually in our ACO, so there could be some real potential there. But have you included them at all in the dual model discussion?
They're sitting at our table. So there's a representative.
All right, good. Thank you. And just to support Carmela's and everyone's observations, form follows function. The better we can conceptualize and harmonize the efforts and better understand the roadmap, that's helpful. So thank you.
Okay, are we good for the moment on the dual eligible? Anything else? Eric, I'm not sure if I ever answered your question satisfactorily. Did I answer it for you?
He's got to carry it.
I'll carry yours. It's a little ambiguous to me, and perhaps will become clearer when the group presents to us. To me, it's an important issue because you've now put it in here as one of the pillars of progression. And so I think it begs the question, how does it all work? How does it interact? And we should probably be cautious with our use of terminology. As you pointed out, guardrail maybe wasn't the right word. Because it seems to suggest what we're doing on the big loop.
Right. Yeah.
At least it doesn't lend itself to the same calculation that we use for Medicare, which is to look at the national growth rate compared to the Maryland growth rate. That's the way that we measure cost growth today. It doesn't fall into that because we don't really have a national growth rate benchmark for the duals cost, and so I think for sure, Eric, it does warrant more details on measurement.
Maybe, Donna, just one other comment, and again, because it features prominently in the PowerPoint, in the text document. I think to put as much detail in about it. I mean, if your concept is that it gets shorthanded sometimes as the dually eligible HCO, yes, here's one. I don't know if that's the case. I don't know if I heard the notion of people forming them and them bidding on a particular geography or whatever. And so to the extent that there's details, I think it would be helpful for all of us to understand it. Because to me, when you say the dually eligible ACO, it would suggest there's one thing. If it fails the test, somebody has to make up the difference. Who is that person, et cetera. Right? So maybe the details.
As I was reading the materials and getting ready for the meeting today, one of the thoughts that I had was that I didn't feel an all-payer tone coming through, or a sense of how this is sort of an all-payer in the marriage. And I asked Ben earlier today, this afternoon, what has happened to the state health expenditure accounts that MHCC is maintaining. And I think if we think about this at that global level, and think about how you monitor spending in different sectors of health economy, and begin to sort of think about how would we measure what's going on within the duals, within Medicaid, within Medicare, and is there a common structure? It doesn't have to be a common set of metrics that for evaluation purposes. It doesn't have to be a common set of payment models, but just a monitoring system laid on top of this that gives you sort of a unified structure to measure what's happening. I think would be very helpful. It might help clarify some of the questions that are being asked here.
Good point. Thank you. So why don't you resume,
Okay.
taking us through, because we got, two documents and.
We do.
Uh,
As far as other changes that have been made, I would say they're not as substantive as the dual eligible. We certainly took the comments that you all sent us. We integrated them in here to provide more clarity. As I said, you had the chance to have a look at them. We're still open to accepting comments on this document, and so I think we're good with the blueprint now. Unless, Dawn, is there anything else that you'd like to say about the blueprint at this time?
No, it's just it's a working document, so.
Yeah.
maybe ready for the slide deck?
Yep.
We're now turning to the slide deck. Is that going to be up on the?
I think we have to change the, you want me to do the clicker for you?
Good. So the slides are up on the screen, either that one or that one.
So again, we showed you this at our last meeting when we were looking at the blueprint, and this is the all-payer, the strategy that was laid out in the original all-payer model application. And we're showing it again because as we work through all of the work that we're doing right now, where we're laying out the progression and we're thinking about the models that we would include in it, that when you look at the primary drivers, the secondary drivers, and the aims that were laid out back in 2013, that these are still very close. I mean, we're still heading down the same path. There's really, we're adding some things to it, but there's really no change. I really want to give you every opportunity to chime in here too, Donna. So, and, yeah, okay. Again, as we've talked about in this, as we've talked about before, the stakeholder-driven strategy for Maryland is about care delivery, health information exchange, and provider alignment. And sometimes we spend a lot of time talking about the payment models, right? Because the payment models are the structure that many times that these changes are taking place within. But the important thing, and one of the things that we've been talking with the dual eligible work group about, is making sure that the real goal of everything we do is around changing care delivery. It's improving the delivery of care to the patients in Maryland. Well, how are we going to redesign the actual type of care, the preventative care, the coordinated care, what we're going to do with the patients themselves in order to improve the way Maryland's healthcare system works? What are we going to use in terms of technology to support those changes? And then how do we get everybody working together on behalf of the patient? So we've looked at this slide probably 10 times before, but just reminding ourselves that that's really the intention of what we're trying to do. Again, we've looked at this slide before. We've said that, you know, as we started the all-payer model, in year one, we really started to get a handle on the hospital metrics, the meeting the goals of the all-payer model that was agreed to with CMS, and we achieved that. In year 2 and 3, to work on, again, improving care, partnering across hospital physicians and other providers, and aligning and planning for the future. As we move into years 4 and 5, the intention is to implement the changes, focus on the alignment models, and really start the engagement with the patient. Again, these are all the things that we've talked about over all of these months, right? And just as a reminder that that's where we're headed. Dawn, I want to give you the chance to add anything to that.
You know, I just think really just focusing on the context of really building out the things that make the existing approach that we outlined to CMS successful. And really many of the things that we're talking about here were laid out in our initial plan. They're not new, but we're now at the point where we're trying to build them out and plan on how we evolve them over the coming years.
Okay. When we get to slide 7, this is where we started to make recommendations on how we might change the driver diagram that will need to be submitted to CMS. And we highlighted in yellow some of the changes. So we're recommending, or I guess putting to the group for discussion, let's put it that way, that the updated aim would be over a 10-year period, achieve the goals of better care, better health, and lower costs, driven by a person-centered approach to health care that optimizes outcomes and values for all Maryland residents. We're extending the time frame. We're submitting to you the idea that we would limit the growth in Medicare total cost of care spending, including the Medicaid costs for dually eligible beneficiaries. So it's part of the strategy, not necessarily part of a change in metrics for the all-payer model, but certainly that we're calling it out as part of the strategy for Maryland. And improve efficiency and quality of episodes of care. Donna was talking about long-term care, about post-acute care, and thinking about building models where we would, improve the way that we're managing episodes of care, in addition to the other concepts that we have on the diagram. That we would consider all patients, all payer principles, and their application in the development of models, measures, and infrastructure. So as we're building for Medicare as the priority, and certainly Medicaid is coming, the dual eligibles are coming along as well, that as we build, we keep in mind, how could this be applied to all patients and all payers over time, as opposed to limiting ourselves to the immediate focus that we have of Medicare. Good.
Okay, quick, just over a 10-year period, does that mean the 5 we're already in plus 5 more?
Yes.
Okay.
Yeah.
The reference to episodes of care, frankly, makes me nervous in this context. And the reason has to do with population you're dealing with. You're really dealing with people who have multiple health conditions. And to try to isolate them or focus on episodes, just go there. I think that you're in trouble.
And I think we do have a very significant focus on avoidable utilization and focusing on chronic conditions, but we do have a high variation in how things like hip replacements and things that actually do lend themselves to episode measurement are done, and so we don't want to forget the importance of that as we develop our models. And so as we look at the cost, 55% of Medicare's cost it occurs in a hospital in Maryland, and based on our rough calculations, about 75% of the total cost of care for Medicare is attached to something that started in the hospital, either post-acute care or the doctors who are caring for the patients while the patient is in the hospital, so about 75%. So we want to make sure that we're noting that we also need to pay attention to make sure that episode is delivered efficiently. So focusing on better health and preventive care, on better health and better chronic care, but also on efficient episodes of care in the production of high quality, high value health care is really how that's thinking. But we're not thinking of overtaking the model by veering off the path of total cost of care into a whole different direction that is driven off of bundled payment.
Yeah, and I understand the motivation. All I'm saying is, well, two things. One is CMMI and CMS is very sensitive to this issue of episodes of care population. And, you know, I think if you want to go there and call that out here, then just add another bullet. Put this in some context. It really references episodes of care, but then have another bullet that talks about more of a holistic view of patient status or however.
Okay, thank you for that suggestion. Maybe it even could be moved over in the diagram a little further over to one of those secondary drivers, like where we have care coordination, to have coordinated, efficient episodes of care, to move it over.
Jack, in one of my comments, but I sent my comments through Carmela, whether it's primary or secondary, the reality is I believe we're still relatively silent on this issue, which is the resource pipeline. Because the primary, secondary driver is obviously primary care and advanced practitioners. And the limitations in terms of production systems around output, around those resources is something that's very real. And particularly in more rural areas, access to. So it impacts directly from an access perspective. Not sure how it fits in or how you see where you'd want to plug that in, but I do think that it's something that we have to recognize in the plan. Primary care physicians, whether they're internal medicine or family practice, are limited, as well as APP. So it does constrain us on many fronts trying to improve access.
Okay. So as we looked at, I just did this one, we can flip it. So, I mean, when you're thinking about a progression strategy and asking yourself what are the models that you build, what are the important things that should be looked at when you're looking at transformation? It's important to make sure that everybody's clear on what the cost structure looks like currently in Maryland. The all-payer hospital revenues is about $14.8 billion. About $4.8 billion of that is Medicare. The non-hospital spend for Medicare is about $3.9 billion. So that $3.9 billion, that's when we're thinking about primary care models and post-acute models and long-term care models and some of the things that we talked about briefly last time. We said that we wanted to delve into more this meeting. This $3.9 billion is an important part of what we're talking about there. How is that being managed? And how do we want to think about managing those kind of costs? The Medicaid cost for the dual eligible patients is about $2 billion. So as you know, as it came up earlier, for the dual eligibles, there's a Medicare side and a Medicaid side. We've laid out on the sheet that Donna pointed out to you earlier some more details around how the different cuts of the spending in Maryland and the cost of care. So as we're prioritizing and as we're thinking through the models, starting with the numbers is going to be important. Dawn, I want to give you the chance here to add, what your context on this one.
I just thought it would be important for folks to kind of get a sense of, what is it that we're including in the plan. So we're continuing the plan for a hospital model that is roughly $15 billion, and then laying out the pieces that really are in addition to the hospital model so that you can see what is outside of the regulated hospital environment, and how will we have to integrate approaches to deliver care across the spectrum for these other providers, and how does it fit into the total picture. Not losing sight, as you all have pointed out in the Advisory Council report, not losing sight of the $15 billion of hospital spend that we're still focused on as part of the continuing progression of the model.
Can I ask a question, Deb? Maybe this is for the final report. Hear you that the numbers are important, but I think about what we've done under phase one of the model, and it really wasn't about the number. It was about potentially avoidable utilization. It was really from the clinical side. And I wonder if we might want to think about reframing this. And I don't know the answer of the $3.9 billion. What's the potential for unnecessary utilization or avoiding unnecessary utilization? I worry that this can begin to look to outsiders that it's all about the money. And we have yet to justify, is the money being poorly spent? I'm certain there's plenty of room for efficiency, but is the money being poorly spent? Should this really be about opportunities to avoid unnecessary utilization, as opposed to $3.9 billion is a lot of money, and that's
It's certainly it is about the care delivery, and I think we talked about that at the beginning. It's definitely about the care delivery, but the reason that we do include the numbers here is to make sure that we give folks in the room some sense of how much additional money is there that we're trying to gain responsibility for, and then making sure that as we do that, that we have care delivery opportunities and potentially avoidable utilization reduction, but also appropriate risk mitigation strategies so that we don't ask folks to take risks for things where we don't have risk mitigation strategies. And I think it is helpful for folks to know how much money is involved so that they can work with us in thinking about risk mitigation strategies, care delivery improvement and risk mitigation. So it's one thing to take responsibility for your own budget. It's something else to take responsibility for someone else's budget. And so how do we make sure that we bring the right providers to the table to help take responsibility, and also to have appropriate protections in that process for potential losses. So here's a slide that we've looked at before as well, where the idea is that we take 900,000 Medicare beneficiaries, and we make sure that we have set up structure and interconnection to manage all of them in one way or another. Right now, we currently have ACOs with about 200,000 beneficiaries in it, a medical home, or other aligned models. The dual eligible model, which will account for about 91,000 beneficiaries. And then as Donna has mentioned to you before, we're thinking about the geographic model, where the hospitals would get involved in taking some accountability, all that needs to be worked out for a broader set of services in their geography. So Donna, again, I want to let you speak to this one and describe how you're thinking about this. Yeah, I just, my microphone is off, so it doesn't want me to talk. Sure, this one. It doesn't want me to talk.
But we do.
We're just trying to make sure that we're keeping in perspective all of the beneficiaries, and that we really need to have a plan of how we're going to tackle the cost of care for all of the beneficiaries and even though we have several $100,000 already in ACOs and folks are focusing on those several $100,000, that we ultimately need to have a thought process of how we'll tackle all or nearly all of the needs, care needs for the beneficiaries, and how that will come together. And the numbers of people that are attached to each box on this page are not meaningful, and as time progresses, then and some models succeed and other models don't, then the numbers would be expected to move around. So we may have more ACOs. I think we have some folks who are getting ready to file for ACOs, so we may have more ACOs, and meaning that we might have fewer folks in another box. So I think it's just really trying to frame the conversation of how are we going to think about and tackle total cost of care. What are the opportunities as we work through this process for the strategic plan?
So these numbers are hypothetical.
They're hypotheticals. They have question marks on them because they have no significance other than that they add up to about the total number of beneficiaries.
And there could be other boxes we could add.
There could be boxes added or boxes subtracted.
But you don't think of global budgets as a model?
Global budgets are on here as a box, but they're on here with a geographic presence. So I think global budgets are actually part of each and every model here, because global budgets are a payment and delivery transformation for hospitals, and they form a core part of ACO cost control, of any medical home cost control and delivery systems, of dual, and of a geographic model. So they're just like we think of a primary care model in the same way as forming a core part of each and every one of these models, and we also think of the hospital model as being a core component of each of the other models.
So where do you break out Medicare Advantage plans and then other aligned models?
They're definitely focused on the same thing, and so the global budget is part of the Medicare Advantage plan. It's part of the Care First, patient-centered medical home process, or the Medicaid managed care programs. But we don't have the right here. We're focused on the Medicare beneficiaries, just because we're putting some special attention on planning for them based on our January 1 requirements. However, as we do so, we need to continue to ensure, as Carmela said, that we're focused on how are we going to avoid potentially improve care in hospitals through avoiding potentially avoidable utilization, and that affects all payers. So it is a continued part of the discussion of the strategies that are being applied to Medicare beneficiaries that are also appropriately applied on an all-payer basis, and the importance of that to the success of the hospital model on an ongoing basis.
Raising that, I think it's important that the Medicare Advantage beneficiaries count against the total cost of care calculation.
Absolutely for the hospital. For the non-hospital components, today they're carved out of the total cost of care.
So it's sort of, I guess that was the point I was maybe making explicitly, because there's sort of a different population in terms of as we think about management.
Yes, and then of course, as you know, Ben, the Medicare Advantage rates are set based on the fee-for-service rate. So if we have a cost savings on the fee-for-service side, it pushes over into the Medicare Advantage side. So there is a relationship of savings, but we're not having them in this strategic plan as a focus, because indirectly, there is a focus on Medicare Advantage, because if we save money on the fee-for-service side, it will move its way over to the Medicare Advantage side.
I think you
No.
keep going, yeah.
I've got somebody coming to look at the other.
Willing to be quiet? No, I think we should. I was saying we could leave it in front of her and let Donna keep going on some of this. I actually think that we need to hear from you on this, on some of this contextually, Donna. I do think it's more, there's some. I think you should go ahead and keep going. Yeah. Probably don't have any microphone issue.
I get the other one working.
Well, I think the next slide really just starts is really setting up the progression of how do we start addressing total cost of care. And so part of that is really starting to get the data and the data to support care coordination and chronic care improvement. And we've been working on getting that data. I think a data use agreement process is underway on some of that data now, and we've been working on an amendment to the model to get the more detailed patient-centered data that would support care coordination, chronic care management. And then as we get the data, that the system, the delivery system begins to learn how to utilize the data and to use the data to make changes we're really not wanting me to talk. So I can be very loud. Can everybody hear me? So I'll just be loud. So that as the delivery system gets the data, that the delivery system begins to focus on the opportunities to reduce avoidable utilization through better care, to focus on variations in how episodes of care are occurring that represent avoidable utilization, by focusing on a medical home approach that cuts across all the payers and models, as we just talked about, that really is a critical part of a Medicare Advantage plan, a critical part of Medicaid managed care, and all of the models that are in place. And really continuing that focus on the patients with the high needs and the chronic conditions that Dean was referring to as we dive into the data and figure out how we're going to move forward. So starting that process now with the data as we begin to move towards the second phase of our model, and hopefully begin to hit the ground running, if you will, by getting started on it now with the data and learning what we need to do to move forward. So that's really the thought process that we're engaged in, hopefully with you, in terms of driving forward. And now I think we're back to Deb. And I know we can speak up here. Okay. So we added some strategic considerations based on our conversation last time and stakeholder input that we have listed here on slide 13. Allowing all system components and consumers, including physicians, long-term care, behavioral health, and others, to participate in care delivery and payment transformation. I mean, it's really the care delivery transformation that we're going after, and the idea of having everybody working together over time, actually creating an integrated, not necessarily owned by integrated, but where people are working together on behalf of the patient, is where we are submitting to you that is where Maryland should head. And the payment mechanisms are used to support that actually happening. Whenever you
put money and incentives and resources, like we're doing with the amendment, in place to actually allow people and facilitate people to work together. That is when the whole provider community can start to act on behalf of the patients together. Align hospital and provider performance measures and incentives. Like, whenever you have incentives that are working against each other, you have a problem, right? I think it was actually in this room where somebody said one of the problems with incentives is that they work. So if you don't have incentives set up properly, then you have people working against people. They're probably not intentionally, but it happens. And so the idea of aligning the resources and the incentives is important to moving in transformation along. Supporting providers and practitioners in practice transformation and streamlining administrative. Well, in the work that I did for Humana back in the day, before I got into consulting, the thing that the physicians constantly said to me was, you are in here saying to me that you want to give me more money for doing certain things to improve quality and improve the cost structure, but you and 10 people like you all do it slightly differently. You want me to do a different set of metrics, you want me to fill out a different form, you want me to submit it in a different report. I'm trying to take care of patients. You guys get your act together and come back and talk to me, and then I will work with you to try and make a difference to how this is all functioning. And I think this gets lost a little bit. Oh, thank you, Greg. I think sometimes it's easy to lose sight of that from the people who are actually delivering the care. You know, I would go in with these fabulous incentive programs. And I'd be like, yeah, that's fabulous, except I only have 100 of your patients, right? So this doesn't really mean anything to me. So this is something to think about and talk about and consider as we're building the models and the strategic plan. Assisting providers with qualifying for additional funding under MACRA. So obviously these financial incentives are important, but what's more important is the transformation that this payment change is set up to affect. So we need to help the practitioners and the providers' offices to actually make the transition so they can get to the money. But it's more like so that they can take better care of their patients. And oh, by the way, this great side effect is to get the extra money. We need to leverage current strengths, work in progress, and available funding from the government. So again, I think back to Carmela's point and the point that many of you make, we have got to make sure this can all function together. How does the dual eligible ACO relate to Eric's ACO? And how does the primary care model relate to the GBR? And how does all of this function together? And I can tell you, just in terms of trying to figure it out, that it's not easy. That is not an easy thing, but it's something that we need to do. Donna talks to you many times about ideas on how that can be done, and what we have to do is just get our heads into it, get our shoulders into it, I think was the term she used earlier, and really figure out how it all functions together at the resource level, at the integration level, at the payment level, how it all functions together. Kevin?
I think that's a really good formulation. If I could paraphrase it back to you, you're saying basically change is the goal, change for the better, and you want to make payment support that as opposed to be the end in itself.
Yeah.
And then within payment, getting the incentives aligned across the board is critical. I would just suggest that you think about one other element, and that is that you have a chance to succeed. And I think the intellectual breakthrough of the waiver was shifting the focus from competing against other states to living consistent with our GDP in Maryland. And as we shift to Medicare as our focus, I feel us shifting to compare to other states again. And I worry about, you talk about two systems that are not aligned, how Medicare pays everybody else and how they pay in Maryland are not aligned. And if we don't get some consideration into this equation macro, I fear that we will have all, you know, all the elegance if you want. You can't get there from here. Even with good performance, I think you've got a real problem. I don't think we've been upfront enough about that. It's not an easy problem to fix, but it is an important issue here. Because when you look at what the actuaries are saying about the country, they're saying we're going to grow healthcare spending 18% faster than GDP for the next 10 years. And we're hoping to not do that. That should be unbelievable. But you could still not make it because of the way the systems do not line up, Medicare versus everybody else. And I just think we can't ignore that. You just won't be able to win.
And I think we did actually, you made that comment last time, we did actually change this draft to try to weave that into the principles a little bit more, the recognition of that issue, and that we need to think about other ways to, potentially other ways to fund shortfalls than always pushing them across all payer. There may be some things in particular that we need to think about in terms of how to fund Medicare shortfalls. I mean, if you look at the timeline that we have here, Medicare or people over 65 are going from, roughly from 14 to 18%. So it's really a very significant growth in the Medicare population. In my head, I was thinking it would take the Medicare proportion of the hospital spend to above 50%. So we do need to think about it, and so we'll set aside some conversation for how would we think about funding divergent shortfalls, and if there could be some other thought process there, particularly as we cross between hospital and non-hospital, and thinking that in our existing hospital model, we do have a payment mechanism for alternative payment models that is balanced outside of the hospital budget. And does part of that thinking apply as we take on total cost of care here when we have our bundled payments for under those alternative arms, alternative rate mechanisms for transplants and joint replacements and all of the myriad of things that are under those alternative rate arrangements now, and including consideration for Medicaid managed care arrangements, that maybe we need to have also one that applies to Medicare arrangements.
I just think it's going to be overt with CMS as well.
Yes, I think it has to be overt.
The way we're going to try to finance it ourselves.
No, it needs to be overt.
Yeah, and, Kevin, I think another way to look at your point is we had a respite in this country from exploding health costs for a couple of years. Medicare actually, I think, was level or actually down 0.2 1 year in total Medicare spending. Everybody was, I kept telling people, don't open the champagne corks yet. I've seen this before. But now, if you look at the 10-year CMS spending for the whole country, last I looked, it was 6.2% average annual. Okay, let's say Maryland keeps beating a 3.58% per capita. Run that out against 6.2. I realize that I'm doing apples and oranges here because it's hospital only against the whole country. But I think an implication of what you're saying is if Maryland is able to beat that trend, which itself has risen back to more normal, meaning not good from a cost control point of view, we ought to get some real credit for that. I'm not sure people realize how unprecedented it would be, since we have a 40-year experience of health spending exceeding the rate of GDP by on average 2.6 percentage points. So if a state finds a way to get, we talked about this, to get that down to 1.6 percentage points or 0.6 percentage points, that's a shocking victory, at least some of your points. So let's make sure we get some credit for that and hold on to it. We may need some of these other tools. We will need some of these other tools in the post-acute world, in the physician world, and nursing home, reducing people going all the time to the hospital, the nursing home and back and back. But we shouldn't lose sight. Is that an implication?
Yes, and I think one of the places we might want to look, just laying some of that groundwork, this is a very good chart of laying out, what the targets were and how we've done. But the all-payer one stops with our per capita, but everyone else, every other one compares to the rest of the country. Why don't we compare that to the rest of the country as well? I recognize it's not an indicator but it is a critical tool. Because over time, in terms of impact on Maryland's health, that's probably the most important. You outperform the country consistently over a long period of time. How much money you put into healthcare and your people are still as healthy or better, it cannot help but help, and not by a little bit.
And we'll focus on trying to do that. The interesting aspect is that for a country that's so obsessed with the cost of healthcare, we certainly have a deficit of comparative information, particularly at a state level. And our cost growth that we have in this chart is revenue growth, and the best data that we can find for the rest of the country is spending growth, which is different than revenue growth because it doesn't include uninsured persons, whereas our numbers do. So we have some translation to do, but we should try. We should try.
Let me see if there's anybody on the phone.
If I can inject one little voice from the road here.
Yes.
I think that was an excellent point about being able to look at the investment we make in our health care as it relates to the health of the state. As you know, we ranked 18th in the nation in terms of the health of the state, 18th from the top, which is a fairly good position, but we have been slipping lately. We went from 16 to 18, driven largely by violence and not by other health concerns. So one of the things I think as we look forward is that as we make these smart investments, they're really improving the health of the state. If that's one of the measures that we want to look at, we need to be particularly paying attention to not only the medical, but the non-medical determinants of health, the social determinants of health, which can be as powerful or even more powerful in terms of improving those metrics.
Good point. Thank you.
This is David Blumenthal. Can you hear me?
Yes.
Just a couple of comments. First, Donna, you may have looked at the Commonwealth Fund state scorecards and also our local scorecards for accounting for comparative cost and quality of care. If you haven't, you can find them on our website. But we update them annually, and we just produced a local scorecard if that's of interest to you.
Mm-hmm.
So point number one. Point number two, I was relieved to hear the discussion about delivery system reform, because one of the allocation of patients across payer category and even across large organizational forms like ACOs or bundled payment or medical homes can really divert and obscure attention where it's needed, which is the incredibly difficult, prolonged, and uncertain journey that the state faces to change the way patients are treated, especially patients who account for most healthcare spending, who are also the patients with the most healthcare problems. So there's really no conflict between the clinical needs and the cost objectives of your strategies. But if too much time and effort, too much time and attention is devoted to the payer categories and the institutional structures, there's a danger that you won't come to grips soon enough with the very, very specific micro-level care modification requirements, which are themselves incredibly difficult and uncertain. The Commonwealth Fund has just joined with 4 other foundations to try to highlight opportunities to improve care for the sickest and most costly patients. And we'll be working on that with colleagues over the next months and years. But if it would be almost a relief, though I understand the limitations, it would almost be a relief if you could put aside the payer categories and start talking about types of patient and how you're going to meet the needs of those categories of patients, almost irrespective of payer category, whether they're a dual or not a dual. Their needs are not defined by their payer eligibility. Their needs are defined by their clinical presenting problems. And there are Medicare patients who are a lot like duals, they just have more income. And there are commercial patients who are a lot like duals, they just are commercially insured. Ultimately, seeing patients in terms of their needs is where you will make progress. And one can spend a lot of time maneuvering among the current regulatory environment and the current payer streams without getting down to that really important level.
Thank you, David. That's a very good point. Anybody else on the phone? Certainly feel free to pop in anytime.
It's Willarda Edwards.
Hi, Willarda.
And I have no comment, just wanted you to know I was here.
Oh, good. Thank you for joining in. And if you do have a thought, let us know.
Will do. Thank you.
Okay. Thank you for all those comments. The last comment on this page is to build in flexibility. There's no way that healthcare is changing so fast that it would be nearly impossible for us today to put together models that are not going to have to be refined based on learning, based on market forces, based on the changes in the provider community, based on the way patients do things, the responsibility that patients take or don't take. And so everything that we think about as it relates to the strategy and the models within them need to build in flexibility and the ability to adapt over time, probably quickly over time, because things are changing quickly and we need to be nimble. Many other industries are, and we can build that in for ourselves. On slide 14, this is just a reminder. I believe we've talked to you briefly before about the care redesign amendment. So as we're building, the strategy, the amendment is like the number one thing that we're doing as the first model, so to speak, that's in there. And that amendment, as you guys are aware, is in response to stakeholder feedback. And what it does is it right now it lays out 2 potential programs, the complex and chronic care program, which to David's point that he just made, what we started with there was complex and chronic patients. And we said it was all payer, okay? We said that even though the majority of these patients will most likely be Medicare or dual eligible, we're going to set this up, we're going to set this program up so that it's looking at the high utilizers who have multiple chronic diseases and are in the hospital a lot. So we started with a patient base, and we said, let's build some resources and a system around those people so that the hospitals can set up a care coordination function that is accessible by the providers, setting up a locus of care. It's not exactly primary care, but it is, you know, there's lots of doctors that could be in it. It can be your primary care doctors, it can be your specialists, it can be your nurse practitioners, any of these doctors that the patient chooses, right? So now you have this direct relationship between the doctors and the patients, and there will be resources available and Medicare data of it, patient-identified Medicare comprehensive data available to those patients. And the hospital is helping to set this all up. They have the infrastructure, you know, they have their global budgets from which that program can come, and it's aimed at a set of patients. The Hospital Care Improvement Program, which is the, you know, previously it was the Gain Share program that MHA had been working on with AMS. And what it is aimed at is the kinds of procedures, building more quality and efficiency into procedures and activities that are going on in the hospital, also all payer. The long-term and post-acute models are the ones that would be considered next on the list of the programs that would be done, again, starting with the hospital budget, starting with the hospital model, and saying, how do we work with post-acute providers and manage the total hospital cost, right, the post-acute care, the episodes, this is where these episodes that Donna was talking about comes in, and also long-term care where you're thinking about residents. So when you think about the dual eligibles, right, a lot of those people are residing in long-term care facilities, but they're not necessarily accessing 24/7 primary care, right? And so they're going to the hospital. So the idea of reducing utilization by connecting, right, the providers and the hospitals together under work that the hospitals are willing to do with under their GBR budgets is what the amendment's about. And that's like the first step in the strategy that is in progress. But, you know, submitting to you is the idea that it is a step that's being taken right now, and it starts to get us moving down the path towards the strategic considerations that we were just talking about.
Joe had a comment.
Yeah, just a couple of general comments. No, I appreciate the outline. You know, obviously HFAM and our post-acute members, we've been kicking this around informally for quite some time, and just wanted to share for the good of the order sort of what some of the things are bubbling to the surface, both in their work with the duals work group with DHMH relative to this. Firstly, the quicker reference is on the work with the dual eligibles, right? So clearly, so in the duals, we have sort of two distinct populations, and I agree totally with the Commonwealth Fund, the observation that there's power in focusing on, you know, their clinical need rather than the setting in which they receive the care. So I share with that disclaimer. But in terms of the group of, you know, 90 or so thousand Marylanders that are dually eligible, you have the folks that actually live in skilled nursing and rehab centers, and you have the folks that are bouncing in and out and sort of going across the continuum repeatedly before at some point they become residents of the skilled nursing and rehab center. So it's sort of two distinct groups. And so we think that the duals work group is gaining traction at looking at how to better clinically navigate those groups. One thing that I think a lot of the folks in the group, the duals group at DHMH, weren't familiar with is that most of the large sort of best in show skilled nursing rehab centers in Maryland, you know, Lorient Healthcare, Future Care, Genesis Healthcare, I'm going to forget some, but most of them directly employ physicians. You know, they have their own physician groups. The idea is, how do you then apply that physician group potentially to help those frequent flyers that are dually eligibles, that are going to the emergency department, then to the hospital, and then repeat flyers in post-acute care as duals, to sort of utilize the system, navigate the system better, avoiding that cycle, right? So that's that general observation. That's the simple part, bucket put aside for a second. On what we're talking about, the waiver, in our discussions, two things seem to be bubbling to the surface with the most sort of, notice. One is the idea of bundle payments, with post-acute bundle payments and partnering with hospital partners, in which not only you have payment alignment, but you have incentive alignment, in which you would have shared risk across the continuum, but you would also have shared incentives for the partners in that bundle to share any a small percentage of the savings that accrue in their setting to their partner setting. So a small bit of the savings that, let's say, an acute provider would make, not the majority, small part, would go to their post-acute provider. And a small amount of the potentially that a post-acute partner would have, the majority of their savings and their benefit would go to them, but a small part of that would incentivize back to their hospital partner, in addition to the alignment. So that's sort of the latest wrinkle that I find very, very, very interesting. The other thing is that when, in looking at the data that we've all been looking at, it seems that there is a difference in the acute length of stay for the Medicare beneficiaries that are then sent to a post-acute provider for additional care versus the average Medicare beneficiary in their acute stay, not in their post-acute stay, in their hospital stay. The folks that are ultimately sent in Maryland to a post-acute setting are staying longer in the hospital in their acute stay than on average just the folks that are being discharged home. So that sort of reinforces, amongst other things, the clinical complex needs of that patient. So we think there's some overlap there to work more deeply in partnership between hospitals and the post-acute world, and again, in helping to treat those sort of chronic clinical conditions. And one thing you could do in that, in addition to the bundle, is counting observation days towards the 3-day hospital stay. So those are sort of the two things that seem to be bubbling up to the surface that I would share for the good of the order on that bucket. But I appreciate it.
Yeah, thank you for sharing that. And as part of that, are you imagining clinical integration, sharing of information?
Yes, in real time.
Joint decision making, things that are beyond the payment model, right? As we're discussing.
Yeah, absolutely. I mean, there's a couple of things. So firstly, we're going to see this speed up on the Medicare Advantage side because of the lack of some of the prohibitions to do that. So we're going to sort of see some of that anyway. But some of the big folks have been partnering this with their hospital partners anyway, like joint cardiac rounds, and actually have the same physicians doing the cardiac rounds in hospital and the cardiac rounds skilled nursing and rehab center. But the idea of doing that more systemically, there's some power in that, and having that clinical focus and sharing the data and sharing the decision making in real time, not in a linear sort of way. Yeah.
Good point. I'll call on Peg in a minute. From the point of view of time management, we have 25 minutes. We have guests today from the SEIU who are going to bring an important perspective to it. And then, of course, as always, we want to allow time for some public comment. So I would say, Deb, however you want to do it, but maybe select the 15 remaining charts or what I don't do them. However you want to do it.
We're just about done, other than the appendix.
Oh, okay.
Yeah.
Okay, I didn't
Did
realize.
you want to?
Just a point of clarification. We went through PowerPoint on the amendment, and there were two buckets, if you will. The goals of care redesign programs, which is the hospital-based care improvement, and then the complex and chronic care, which you just stated would be part of the GBR discussion and come out of the savings of the GBR program. The long-term care post-acute, is that a new model now? A third bucket for us?
What we included in the amendment process to date is to allow for investments in post-acute care facilities, because we were asked by hospitals to allow for investment of resources, and making sure that we covered that in our waivers. So we don't have a shared savings model at this moment, but all of these programs are being launched with options of being able to get data and share resources versus whether there's a shared savings component. Right now, there's no shared savings component with long-term care, but there's an opportunity to share resources because we know that many of you want to actually share some resources with the post-acute and long-term care facilities. So that would be a to-come thought process of how would we ultimately share savings among partners with post-acute and long-term care, but it's not there now. It's not there now, but the sharing of FTEs and computer systems and information is all built in there because it's such an important part of the population that needs specialized attention.
And the amendment is written to be able to add programs as the stakeholders identify them. I mean, there will be a process that we have to go through, but the amendment is being written to allow for additional, that flexibility we talked about.
Mm-hmm. And we're trying to really get some flexibility there, and we're also trying to do everything that we can so that as you continue to develop this, that you may be able to develop macro strategies that can be put together with the amendment. So so it's taking a little bit longer than we would hope for documents. And Mike Robbins asked me, where are the documents? And I said, I'd love to share them with you, but I don't have them yet because we're working on them once again with CMMI to see if we can make them as flexible and macrotize them to the maximum extent that we can so that we can hopefully use them in a flexible way going forward so that they're not just some short-term strategy, but they actually could become part of how we walk forward, and we wouldn't have to be going back to the drawing board every time we want to make a little change.
The progression blueprint makes note of the fact that the CMS is looking at the care redesign amendment. May sign off this summer. It is summer. Is that imminent, or is that sort of a rolling, we'll see?
We're still very hopeful for summer sign-off. I know summer's got a little bit. How many more days do we have left in summer? We're working hard to get sign-off, so we'll ask for an update. As you know, CMS doesn't ever like to formally commit to a timeline, so we are still hopeful of end of summer completion.
Can I ask that question, Donna, in a more cranky way? That is, I'm struck by the juxtaposition of flexibility on one slide and then the gain sharing programs on the next slide, where I think, at least from my perspective, it's been anything but flexible. And so I'm trying to understand the flexibility notion. Is that our desire, or is CMS really a partner in that? The hospital care improvement program we've worked on for 2.5 years. It's been rewritten in ways that are not what we originally envisioned. It's now being looked at for implementation in 2018, which is many, many years beyond perhaps its even usefulness here. It's not feeling very flexible, and I think about all of the pieces we're now talking about where gain sharing already improved in 2 states, New York and New Jersey, was sort of an easy step. Could you talk a little bit about flexibility? Why do we think it's going to be more flexible than a system that we're 3 years into that hasn't been particularly flexible?
Well, we're
just because it's Monday. I'm just cranky.
What we're focused on doing is moving the model building into the purview of the state and having some regulatory oversight over that, but building a lot of the models in the state. So let's say, for example, when you envision the hospital model, the hospital care improvement model, originally it was just DRGs, but now we're all pretty focused on post-acute care as being an important part of the cost structure. So what if you could go back and add that into the cost structure and do the gain share with the physicians based on hospital costs plus post-acute costs, and that we would have a lot of that approval capability as long as it didn't cause the federal government to have to change the way it was paying. So what if we could do that in Maryland, and we submit the protocols to CMS, and Maryland is overseeing it, and we've got all the bells and whistles to do the savings pools here, and we're overseeing them here, and we're not having to go back to the federal government other than for them to say, yeah, nice change, move on and submit. So they are trying to put a lot of capability into the state and the providers in the state to evolve, and a little bit less of the structure inside of CMS, which is really a very long process. So that's what we're really attempting to do with the documents to the maximum extent possible right now, because like you, we don't want to suffer pain to be able to move things forward and be flexible. So it has been painful, and we would like to avoid future pain if we can, so that we can work together more and have appropriate federal control and more state control over the process. So that will lead into a future discussion of infrastructure in the state, because we will have to have the infrastructure to do that, but that's really the thought process that's there. And we're hoping that will help us with MACRA too, that as we think of ways to have physicians aligned productively with hospitals for care improvement, that we may be able to use this structure to help bring them into the equation and work and work closely with us, and then become part of an APM. So that's what we've been really trying hard to accomplish. We're hopeful of success, but that's what we're trying to accomplish.
Okay. Oh, I guess we're ready to go to 15.
So how much time do we have left?
15 minutes.
Okay. So when we get to slide 15, in the progression strategy, we need to lay out the models that we are expecting to develop as part of the progression strategy. Right now, the ones that we are submitting to you for consideration are primary care, the geographical population model, the dual eligibles, which is already being worked on, the post-acute care, integration of behavioral health, and long-term care. We'll need to ask ourselves questions about these models. You know, are these the right ones? Are we missing important ones? What is the timeline, and how should the strategies and the models themselves be prioritized? What is the most important? What do we focus our attention on? Both first, second, third? What do we do simultaneously? What's the best phased approach, and how should we go about developing the plan and the model? I can describe the models right now. I mean, on slide 16, we have a one-sentence description of each of the models, but it might be more worthwhile to spend a few minutes asking ourselves the questions that I just laid out. Are these the right models? Are we missing something?
I'll just speak to what Mr. Blumenthal was saying about looking at the clinical conditions, the chronic conditions, looking at the person rather than the way they might be organized or paid for.
Yeah. So when you think about, like, it's on the programs that we've put together, that we've thought about and put under the amendment, we, as a, collective stakeholders, I would say that they, like I said, the two that are in there are all payer, and they're about conditions. Those are. As we're thinking about things like post-acute, I think one of the things that has to be considered is the fact that we have to make the Medicare test for the all-payer model, right? So we have to make sure that we get the Medicare test, right, taken care of first, right?
Not, I think we have been looking at conditions and people, and we put the pyramid in the PowerPoint presentation a bunch of times, and we still think of the the pyramid as being the core tailoring care to patients' needs and people's needs. And so we should put the pyramid back in so that we don't forget about it. But folks didn't want to repeat too many slides, but the pyramid belongs here. And primary care really is one of the executions of the pyramid, and the chronic care management and risk stratification are elements of the primary care model. And the dual eligibles are almost all high needs patients. Not every one of them, but an awfully high percentage of them are at the top end of the spectrum of needing specialized resources. And so, and the behavioral health patients are at the top of the pyramid in terms of high needs patients. So there is actually a very patient-centered focus to the list of priorities that are here, that they're all of these priorities here are primarily focused around high risk and high needs patients, and so that's the vast majority of what you're seeing here as strategies. That as you start diving down into the strategies that are underneath these, it's about better chronic care and primary care and having a focused method for risk stratification so we can deliver the right care to the right, appropriately to the patient. So the geographic population model is a way of time, is a little bit different than the rest of the things that are on here, in that it is a way of since we have about 200,000 people in ACOs, we really need to have a way of starting to think about how would we structure and organize and tie costs together so that we can measure how we're doing. And so that is a concept to really measure cost progress in different parts of the state. So if we have right now a total cost of care at the statewide level, how do we drive that down to a more local level so we can see how we're doing in terms of not just cost controls, but also in terms of outcomes? How are we doing on improving population health or outcomes on a more local level? But the rest of the areas here are really focusing on people who have high needs and have already hit the delivery system for extensive amounts of care delivered. Does that make any sense, Izzy?
I'll throw out a spot then. In terms of prioritization, I have a bias. Actually, maybe Eric Wagner's bias that I'm about to suggest, a bias towards outcomes as opposed to models. So in thinking about how we would prioritize, there are three things that have come up in the conversation today. To David's point, number one, outcomes that address unmet needs. Second, in my mind, outcomes that have opportunities for reducing potentially avoidable utilization. And for me, the third, and I think Kevin mentioned this earlier, opportunities for success. And those are at least three things that I think could and perhaps should drive our prioritization. When I look at behavioral health as an example, no question that is critically important to us. It is not just a Medicare issue. It is not just a statewide issue. It's a national issue. And I think some of the barriers are just tremendous. But I keep coming at this through the window of potentially avoidable utilization. Some of these opportunities will create greater spending, not less spending. And so I think we constantly have to look at what we are being held accountable or holding ourselves accountable for. So for me, unmet needs, potentially avoidable utilization, and opportunities for success could be drivers to help us begin to choose among some rather than all.
Okay. Thank you.
And sometimes in behavioral health, by addressing the unmet needs and the insufficient number or type of providers, or mix of providers, or they're not accessible, you do spend more money, but you're going to save it in other systems. The state is going to save money. They might not always save it in the healthcare budget, but the juvenile justice budget, the housing budget, the social services budget, because those behavioral health patients are touching all those, banging all those budgets, you know.
And not that that or any of the others aren't a good thing to do, but, and it goes back to, I understand what we're holding ourselves accountable for in this initial phase, and that is not only the hospital spend, but the Medicare total cost of care. What are we holding ourselves accountable for in the next phase, and how much do we know about any of these opportunities to reduce avoidable utilization?
Thank you, Carmela. Did you have a comment?
Oh, I did. How did you know?
I could tell.
I was just thinking about unmet needs, as Carmela said, and I thought about patients I know that he's not going to care about his insulin unless I check and make sure the air conditioning is working. And the homeless guy isn't going to care about his high blood pressure until he finds a home. And I'm not suggesting that it's people in this room are responsible to fix those things. And I know that the pat answer is say, well, have a care manager work it out. Well, the care manager needs to have people who answer the phone, who are responsive. So I wonder what we're doing as a state to integrate and align incentives along with other agencies, both public and private, to answer the unmet needs, because we will have high utilizers who keep coming to us because the hospital is the nicest place in their they can imagine.
Mm-hmm.
Yeah. So somehow that needs to be a priority, is my point.
Okay. Other comments?
I guess there's another thing. So one other priority, somehow patient engagement or public buy-in. We have to engage the public and let them know this is a priority.
Thank you. Okay, so I mean, are we at time? I think we now. So there's an appendix that lays out more details about the thinking around the models that are here. But I think we have to go back as well and think through the comments that we've gotten today, and then prepare for the next discussion. Donna, I'm going to give you wrap up this discussion.
Right. Just one more question. Would you envision using a similar process as you did with the draft report? In other words, you'll take comments from us around the table with suggestions?
Yes. Absolutely. Thank you for bringing that up. If you have a thought, because 3 days from now you might have a thought, you want to put it in an email or a one-pager or whatever, send it to Deb and me, and primarily Deb, and her team will factor it in. I encourage that. So thank you. Did you have any? I'm sorry. I didn't.
Yeah.
No, I did. I think just in terms of the appendix, I would call them notes as opposed to something that has been preconceived or cooked up or finalized. That you're viewing those as notes on the possible models or initiatives, and view them from that point of view. We definitely would appreciate correspondence and input in between meetings.
Good, thanks. Okay, we now have, we're very fortunate to have 4 representatives from the Service Employees International Union. I'm gonna, Jen has been to every meeting, and so she has asked some questions and listened. She's a regular. She's brought some of her colleagues with. We're gonna make a couple of chairs available if I could grab a couple so they don't have to shout at us from the back of the room, and they're gonna give us a perspective on workforce issues. Yeah, that's great. Thank you.
Thank you.
So Jen, if you want to lead off and introduce your colleague.
Sure, and we also have a slide that we prepared. So for the sake of time, I will go ahead and start while they're pulling those up. So thank you again, Jack. As Jack mentioned, he and I were talking about the fact that there's a stakeholder perspective that we thought would be important to share today from the workers and workforce development opportunities. So we were just going to talk a little bit more about our union and give each of our leaders of our union that are here a chance to speak very briefly about their role in our union and some stories of workers' perspective, and also have Brian O'Neill, who's our, thank you, great, the director of our Labor Management Training Fund, give some proven examples of workforce development programs in other states. So our union is 1199 SEIU, United Healthcare Workers East. We represent 100,000 workers in 5 states and DC in hospitals and nursing homes and other health facilities. Here in Maryland, we represent 10,000 workers in over 65 long-term care and hospitals in every stage of healthcare delivery, and they're on the front line giving care and know all too well how rapidly healthcare is changing. So I'll give it over to Jen to talk a little bit next.
Good afternoon. My name is Jennifer Epps. I'm the Vice President at 1199 SEIU Maryland, DC for the registered nurses area throughout the state. Thank you. Thought I was loud enough. So one of the things that we learned, I guess lessons learned from Laurel, you know, we all know healthcare is changing and it's transitioning. Let me know if you can't hear me. Changing is transitioning, and that there's a consolidation of services, right? But I guess the sticking point is that the members or our workers don't readily recognize that in a way that is allowing them to be better prepared. I think the 2 lessons, the big lessons that we learned was not only were workers not prepared for the changes, but you know, particularly med-surg registered nurses and critical care nurses that may, you know, have to do something a little bit different in the future. And secondly, we learned that training is not readily available. The ability to get to the right trainings aren't available. Fortunately, we partner with our Training and Upgrading Fund, and we've been able to get folks retrained in doing different things. So while attempting to retrain them, a couple of examples that we've been able to do. So we've had patient care techs become OR nurses, different, I guess, service and maintenance workers being able to train up to be nurses that fill an actual need. The second thing is we've had ICU nurses go from ICU to the interventional radiology department, which is not a big transition for some if they've had enough experience, but they've been able to go back to the Training and Upgrading Fund to get their bachelor's in nursing. And then we recently trained about 25 ICU nurses to be CCRN certified, or to get their training to be certified if they take the test. So we're looking for more opportunities through apprenticeships and other opportunities to be able to allow our environmental services members, who we think are probably trying almost left behind in this whole change, to become skilled workers, skilled maintenance workers, or other kinds of workers that we actually need in the future.
So good afternoon, everyone. My name is Raymond Dorsey. I'm currently the Vice President of Baltimore Hospitals and Health Systems. and we represent workers in hospitals such as Greater Baltimore Medical Center and Johns Hopkins University. And thank you for having me. Jim makes a great point about, elevating workers and finding those talented individuals that we have right within the institution into those evolving positions. And I have two great examples of workers who have, taken on that challenge and moved from one area to another thanks to, in part, the training fund as well as their employer. Next slide. So Darren Thomas, he works at Maryland Midtown Hospital. What is the University of Maryland Medical Center Midtown campus? I'm still working on that.
Bob,
but
did we get that right?
he started there a couple years ago as an EVS worker. He was a floor tech, and through the training fund and that opportunity, he's now a central sterile technician. And in his words, he says, "Healthcare is changing, and I want to change with it." From the training I received from the fund, I was able to move from my job as an EVS technician to working as a central sterile tech. I believe in the 1199 training fund, and I'm excited to take more trainings in the future. And that's Darren Thomas. And that's a guy who, he lost his parents at the age of 15. His mom actually passed at 15, his dad at 16. And he had to make a decision between, going to work or going to school. Luckily the training fund and with the training fund and the partnership with the employer, we were able to put him and others in a position to progress and move to an elevated level and obviously make more money for him and his family. Another person I would like to share with you today is Alicia Jacobs, and she currently works at Johns Hopkins Hospital. And in her words, she states that I started working at Hopkins as a patient transporter. I love helping people and being the kind of voice to them as they are in the hospital. After going through the pharmacy technician training with the 1199 Training Fund, I was able to get a job in the cancer center currently. Training is a great resource, and I hope many other workers are able to take advantage of it in the future. So she's another person that has faced some challenges, being a part of the LGBTQ community, and taking care of some of her family members had consistently look for the opportunities in the training fund and through her employer. And I think, I sit here grateful that we were able to give her that opportunity. But we would be here all day if I had, shared every single person that I run across. But, we look forward to doing a lot more of that, and I thank you for your time.
All right. Let me know if I need the mic. I may not need the mic.
There are people on the phone.
There are? Oh, okay. Sorry about that. So good afternoon. My name is Brian O'Neill. I'm the Regional Director for the 1199 SEIU Training and Upgrading Fund. And essentially within our fund, take it away from me. Essentially in our fund, we have approximately 5,000 members across 29 different long-term care and acute care hospitals. And, so basically what we do is we provide educational and job training opportunities. You've heard a few of these examples throughout the region and then also in Washington, D.C. But one thing, and I'll make this very brief because I'm just going to highlight a few of the opportunities that we've been able to provide in terms of the umbrella of organizations that deal with job training in other areas as well, in the Bronx, also in Washington State, and then in Pennsylvania as well, where there's some good apprenticeship stuff that's going on in terms of identifying what are apprenticeable positions within healthcare, which is new and developing. But if there's one thing to take away from what I'm saying right now, it's just that we don't have to reinvent the wheel, that there are good, quality, proven job training opportunities and infrastructure within the region, and we just have to invest into those to make sure that they flourish and continue to progress with the ever-changing system. So in the Bronx, which the U.S. Census says is the most diverse area in the country, we've been able to do some interesting work there with the 1199 New York Fund, which is to bridge college for Spanish-speaking healthcare workers, a one-year bridge. Also been able to recruit Spanish-speaking workers to enroll in PCT certificate training programs. As we know, within this region, things continue to diversify within the workforce. Employers also, along with the union and training and employment funds, have been able to develop curricula to support new models in healthcare delivery. And the employer union committees, which we have in this region as well, continue to work together to increase the cultural competency of the workforce. In Washington State, one of the things that we're actually doing right now is mirroring this, working with CE Direct to be able to provide free access to unlimited courses online and accredited continuing education for LPNs, MAs, NACs, here there would be CNAs, and other technical and professional workers. So that's something that is on the plate right now that we're working to replicate that they've done successfully in Washington State. Also, HEAT, Hospital Employees Education and Training. The state legislature actually allocates money for funding of those education and training programs for incumbent hospital employees. We did a program here in the state back in 2013 for incumbent workers through some grant funding in the state healthcare personnel training program. We did electronic training in electronic medical records, also for training for BSNs, where there was the need to fill those slots for BSNs in the region. And we also did a program for certified coding specialists. That was back in 2013. So, and in Pennsylvania, sister unions and organizations that also deals with funding or training, and has also done, their Taft-Hartley Fund, we're also a Taft-Hartley Fund, basically 1.5% of gross payroll by participating hospitals and nursing homes and other providers in Philly to provide training, career ladders, and case managers for 4,000 CNAs and LPNs. We do similar training within this region. And also what's up and coming, as we see in some of the facilities in this region right now, community health workers, right? We're talking about driving down costs. We're talking about going out into the community and trying to reduction in readmissions. So the community health worker is definitely an apprenticeable position. There's been a curriculum that's been developed in Pennsylvania that we can also implement here as well. So these are just a few examples, and like I said, just to keep it short, I just want you all to understand that there are pre-existing training programs here that need to be invested in, and we don't have to reinvent the wheel. Thank you.
Great. So just in closing, we wanted to share a couple of our thoughts for opportunities and goals looking forward. The first is that we are always talking about the triple aim, and we also want you to be thinking about better jobs as part of that aim, so that we're not only obviously improving care and health and lowering costs, but as we're transforming healthcare, we've got this great incumbent workforce that we want to transform as well. The second thing to think about is how critical this workforce is to protecting the waiver and the goals that we just spent 3 hours talking about. Many of the entry-level workers that work in our hospitals and long-term care facilities are part of these communities and could have some ideas about ways to change behavior or to change access to health care. The third opportunity is, as we demonstrated today, we have leaders in our union that can help and offer advice. And Brian, certainly with our training fund, has ideas for comprehensive strategies that have worked in other states to improve quality jobs and improve health, improve wages that have been shown to improve health. And then the last thing, I think Jack mentioned there were 5 rounds of edits to the interim plan, but we would really like to work with you all for some, there was a paragraph that was added at the end about workforce development, but we'd love to get some of these other strategies and ideas on the table as well as we're moving forward in our healthcare transformation. So thank you.
Thank you. Thank you.
Thank you. Thank you.
Thank you, Jack, for doing it.
Well, I mean, I think I can't underscore enough, before you get away completely, folks, the importance of your remarks, that we spend a lot of time around this table, going back 3 years, actually, to an earlier group, and we talk about transforming the Maryland healthcare system. And we've got a lot of good ideas, but we talk mainly about doctors, hospitals, and health plans, and labs, and imaging, and, you know, all the components, but we haven't spent enough time talking about men and women who are skilled employees, not to mention dedicated employees who make all this work. And anybody that's been in the hospital knows the critical nature of that, or even going in for a significant test. So as we're transforming the delivery system and the clinical part, and as activities training and apprenticeship programs. In fact, the whole country does. This is a microcosm of a greater problem that I won't go into. Don't get me started. But it really is important to the state that we not lose sight of this. And as we go forward, we will have more to say about that. You've really added an important dimension, so thanks all for it.
Thank you.
So now we have time for any questions or comments from the other group of experts, which are you all. Any perspectives, thoughts, or questions from you before we close off today?
I have one thing to say.
Oh, yeah, Jean, sure.
Lenny asked me to, first of all, send her regrets that she couldn't be here, but she also asked me to thank you, Jack, publicly for what a great job you've done putting together the report and pulling together all the disparate voices and opinions, and particularly listening to our concerns regarding the consumer voice in the whole process, the inclusion of health equity as a key principle in our report, and the need for greater evaluation at a more granular level than was already in there. So I just wanted to express our thanks for all that you've done to pull this together.
I appreciate it. And I hope she enjoys the rest of her vacation. And Lenny made a tremendous contribution and sent me a few rounds of comments and was willing to chat on the phone. And the report is a lot better for your organization perspective. Thank you. Yeah.
Thank you. I just wanted to, I mentioned last time we were going to be doing a series of forums across the state, and I finalized the flyer and agenda for the first one. I'm going to pass it around. I have some for the audience too. And on the front is the flyer that's going to be on December 14th at MedChi, and we're hosting with Maryland Hospital Association, AARP, NAACP, 1199, and Young Invincibles. And on the back is the agenda for it. And as you see, one of the highlights of the agenda is Carmel is going to be talking about the breadth of fresh care there. And this is the first one of September 14th. I hope you all can come. And then the next ones are going to be October 18th in Baltimore County, October 19th in Montgomery County, October 27th in Howard County. But I'll send around notices of them. And we hope this will be a great way to continue getting consumers involved in health insurance.
Great. Thank you, Lenny, for continuing your great work. Anybody else, either a final thought from a council member or from the group? If not, I think we're done. Any final thoughts?
No.
Okay, so my only job is to remind you that our last scheduled meeting is September 12th. I don't remember where and when, but you'll be getting notice on that. And that's the last one scheduled for this year.
HSCRC from 2 to 5.
Thank you. HSCRC 2 to 5. Appreciate it. You're faster with your iPhone than I am. So we'll hope to see all of you there. And for those who might have still be on the phone, thank you for hanging with us.
Thank you. Thank you.